Welcome, everyone, and thank you for joining us for the Mary Funnyé Goldson Lecture. My name is Melissa Begg, and I have the great honor of being the Dean of the Columbia School of Social Work. The Goldson Lecture is an excellent opportunity for our community to come together and expand our knowledge, and in this case, to promote and strengthen social work practice among child and family support professionals. Established in 1991, the Mary Funnyé Goldson Lecture honors the vision and memory of its namesake, a member of Columbia School of Social Work faculty and a tireless advocate on behalf of children and families. This lecture is intended to keep Professor Goldson's vision and memory alive and continue her commitment and devotion to the field of child welfare. I would like to say a few words about this beloved and revered member of our faculty. Professor Goldson was born in Birmingham, Alabama in 1935. She received her BA from Bennett College in North Carolina and her MSW from Case Western. In 1969, she joined the Columbia School of Social Work, where she directed programs in what was then and still is called child welfare. She was a treasured teacher and colleague until her untimely passing in 1990. Before joining the Columbia faculty, she was director of the Community Consultation Center of the Henry Street Settlement, where she was responsible for the supervision of their comprehensive community health program. She served on numerous boards and was a member of many notable child welfare organizations, including the Citizens Committee for Children of New York. Professor Goldson was also a consultant to the Lower East Side Family Union and to family and children's service agencies in New York, New Jersey, Ohio, and Florida. She was a significant force in shaping integrated and comprehensive services for families and children. Her colleagues have described her as a superb teacher who could light up a classroom with an extraordinary capacity to engage her students. She was a dedicated social work professional and a remarkable person, and I wish I'd known her. Now, I have the great pleasure of introducing tonight's moderator, a truly wonderful colleague and also a beloved member of our community, Dr. Jane Waldfogel. Dr. Waldfogel is the Compton Foundation Centennial Professor for the Prevention of Children's and Youth Problems, co-director of the Columbia Population Research Center, and a visiting professor at the Center for Analysis of Social Exclusion at the London School of Economics. Dr. Waldfogel has written extensively on the impact of public policies on the well-being of children and families. She's published 6 books, I believe, including Too Many Children Left Behind, The U.S. Achievement Gap and Comparative Perspective, Britain's War on Poverty, Steady Gains and Stalled Progress, Inequality and the Black-White Test Score Gap, and What Children Need. Her work and those of her colleagues in the Poverty Center here at Columbia have been in the news continually over the past few weeks regarding the Biden stimulus package, which they predict has the potential to reduce child poverty by half. Professor Waldfogel has served as president of APAM and is a corresponding fellow of the British Academy, as well as a fellow at the American Academy of Political and Social Science. Professor Waldfogel, it's my pleasure to turn it over to you to introduce today's outstanding speaker.
What a nice introduction. Thank you very much, Melissa. And it's my great pleasure to introduce our guest speaker, Professor Brenda Jones Harden. She's the Alison Richman Professor for Children and Families at the University of Maryland School of Social Work. Her research focuses on the developmental and mental health needs of young children who've experienced early adversity, including maltreated children in the child welfare system. As a scientist-practitioner, she evaluates parenting, early care and education, home visiting, and infant mental health programs. Dr. Jones Harden began her career as a child welfare social worker, which then spawned her long-term practice and research interests in prevention science. She received her MSW from NYU down the street from us and her PhD in psychology from Yale University. And she's going to speak with us tonight about early adversity and prevention science. So we're so much looking forward to your talk, and we'll pass it over to you.
Thank you, Jane. So nice to be here with you all. And of course, Jane is somebody not only the newspaper has quoted, but I've quoted many times in my career. So thank you so much for inviting me. I'm going to talk today about the thing that concerns me and has concerned me for my entire career. And that's thinking about little children who are experiencing adversity, but importantly, what we can do about that so that they don't end up on negative developmental trajectories. And I want to bring Dr. Funnyé Goldson into the room. I did not know her either, but I felt a connection to her as I learned about her. I was actually reading a chapter that Brenda McGowan, a former member of the faculty, wrote about her. And I thought there were many ways that she and I could have connected. She, like me, was trying her best to be a scientist practitioner. And I talked to some colleagues earlier today about how tough that is. She was a consummate advocate for poor children. I wish I could sort of in my life with having done as much as she's done to advocate for poor children. She also was singularly focused on kids in the child welfare system, and I have done that for the entirety of my career, and really worked hard to think about what kinds of innovative programs we could create to better these children's lives. So she was a person that I felt a lot of simpatico with, and certainly wish I had known her, and am honored to be doing this lecture in her name. So I'm going to talk about something that I like to call triple jeopardy, and that is the impact of age, SES, and race ethnicity on children. And you can already see who I'm talking about. I'm talking about little people. And as I became more and more enamored with this notion of trying to prevent child maltreatment and prevent foster care and prevent children from having negative developmental trajectories, I started getting earlier and earlier in my work in terms of the children that I worked on behalf of, because I became convinced that if you're really serious about prevention, you want to start at the very beginning. So I'm going to talk a little bit about one of the things that makes those children experience triple jeopardy, and that is child poverty. I
So
think.
Brenda, we're not seeing your slides yet, so.
Okay, thank you.
You're
Thank you for
welcome.
letting me know.
It was such a wonderful introduction. I thought maybe you were introducing and then moving into your slides. So
Thank you for letting me know that. Very good, because that would have been terrible had I kept going and you not been able to see my slides. Okay, just give me 1 second. Okay, tell me, can you see them now?
Yes.
we can. Yes,
Great.
we can.
Okay, thank you ever so much for pointing that out. Okay, so I want to talk about child poverty a little bit. And you all probably know that there's been a decline in child poverty. Yay, we are happy for that. But when you look at the youngest children in this country, you see that there is a disparity. So certainly the younger you are, the more likely you are to live in poverty. And that makes intuitive sense if you think about it. Young children are often with young families who have not really gotten good labor force participation and jobs that are well paying. So of course, it's not unusual to look at these data and see that we're talking about the littlest of kids experiencing poverty. But also, remember I said there's that triple jeopardy issue when we look at young children of color, children who are African American or children who are Latino. What we see is that those children experience even higher rates of child poverty. And you can see that big bar in the middle, almost a third of African American children who are infants and toddlers are likely to experience poverty. So already we're seeing this race poverty conundrum that we have. Now, I want to dig a little deeper in the poverty issue, and this is from the National Center for Child Poverty, great resource for any of you who are looking for data on children's poverty. We know that almost half of little kids live at about 200% of the poverty threshold or less. That's a lot of kids. I would argue that that's an epidemic, if you will. About a quarter of little kids live in poor households that are below the poverty threshold, so at about 100%. And you all know the poverty threshold in this country is awful, like about $24,000 for a family of four. Can you imagine living off of that with two children? But we also know there's an increase in the numbers of young children who are in deep poverty, and that's less than about 50% of the poverty threshold, so down about $12,000. So imagine trying to raise children making that kind of income. Now, not only do we know that young children are more likely to experience child poverty, we also know that poverty has a pernicious impact on children in the short term and in the long term when they're young. And I'm going to talk about that a little later and why that is. But part of that, what we see is these socioeconomic and racial disparities that occur because of that in terms of maternal and birth outcomes, but also later developmental and mental health outcomes for children. And then on the other hand, we also see these issues in service trajectories where we see also SES and racial disparities. So in terms of accessibility to child welfare services, to education services, to health services, to mental health services, we also see poor and minority children less likely to experience those services and certainly less likely to have quality services. So just a little bit more about racial disparities. I'm sure that any of you who know the public health field have learned about this horrible problem that's been very challenging to address, even from public health experts, the high rates of infant mortality and morbidity among African American children. And I'm going to talk a little more about that. I have a study that I'm going to share with you about that in a minute, but obviously, what we're learning is that African American infants are more likely to die in the first year of life. And guess what? It's regardless of SES. So the first thing you want to think about, as I told you about this correlation between poverty and race, okay, well, we have this conundrum in the United States of this very strong correlation between poverty and race. But in this instantiation of infant mortality and morbidity, it crosses SES lines. So certainly that's a major disparity that we have to think about. We also know that African American little kids are less likely to have regular sources of health care, and alternatively are likely to have more likely to have illnesses, including things like AIDS, which of course we know we've addressed in many, many ways, but we see that African American children are still getting the AIDS. We also see higher rates of developmental delay and higher rates of mental health vulnerabilities in African American young children. So I want to think about this in terms of these kids that I'm really very interested in. You heard from my very nice introduction by Jane that I've been a child welfare worker. So I'm very, very invested in looking at the epidemiology of these children, their trajectories in terms of service receipt, but also their outcomes and what we can do to improve their outcomes. And one of the things that we've learned, and I have a good colleague, Fred Woolshan at Chapin Hall, who talks about this all the time, that you have to think about the age valences and what those mean in terms of child maltreatment incidents, but also foster care incidents. And what we learned from his work, and certainly from NCANs and other kinds of data sets, that children under 3 are most likely to experience maltreatment, no matter what type, with the exception of sexual abuse. So over a quarter of maltreatment victims are under 3, and about a fifth of them are 3 to 5. Now, one of the things that Fred Woolshan also helps us to understand is when you take apart that under age 3 group, you see an even higher proportion of children under 1 and even higher proportion of children under 3 months of age being maltreated. So it looks like what's driving these data are very, very, very young children, little infants who are being reported for child maltreatment. Now, in terms of fatalities, you would imagine the same thing, right? That if the children under the age of 3 are most likely to experience maltreatment, to be victimized by maltreatment, then certainly they're probably the group that's most likely to die as a result of maltreatment. And that is in fact what the data tell us. So over 70% of fatalities as a result of maltreatment, that's what we're talking about now, as a result of maltreatment, occur when children are under 3 years of age. And when we think about little kids under 1, remember, you know, we have to keep going down, that those children are 3 times as likely to die from maltreatment as a 1-year-old. So again, when we think about child welfare, and you're going to hear me argue this point in a second, we really have to approach it from a developmental standpoint and think about what kids are coming into care and what we can do, what unique things we can do to address their needs and the needs of their families to avoid them coming into care, obviously, but more importantly, to avoid their experience of maltreatment. Okay, so just like you would imagine, if they're more likely to be maltreatment, it's the same story, right? The infants are the largest group that are coming into foster care, and social workers are thinking, as they should, that these are children that cannot go to the neighbor and say, "Can I have a peanut butter sandwich?" These are not children who can run away from an abusive parent. So social workers err on the side of caution, as they should, and often bring these children into foster care. When we look at babies under the age of 1, 4 times more likely to be placed in care than kids over the age of 1. And certainly about half of the kids who are entering the foster care system are under the age of 6. So what does this epidemiologic data tell us? That there is a group of children, young children, who are much more likely to experience risk factors. So from my vantage point, from a preventive standpoint, we should be thinking about these children as a unique group and what we should be doing to address their needs. Okay, now I'm going to go into my sort of psychology conceptualization for you. And part of the reason this is important to me is because I like to think about the epidemiology and that making the argument for why we should be working around setting up prevention programs for these children. But then I want to think about their psychological functioning. And this is one of my favorite graphs to show. It comes right out of Neurons to Neighborhoods, which many of you might remember, that big tome that looked at children's development from 0 to 8. And what this particular graph tells us is that children's brains are very, very plastic in the first few years of life. And I'm sure many of you have heard this. It's been talked about in science, in public media, even legislators are now talking about this. And basically what you're seeing here, if you look at that red part of the graph, for example, it suggests that the peak of language development in terms of synaptogenesis, creation of these synaptic connections and creation of neurons occurs when children are around 6 to 7 months of age. What does that mean? Is that if children are getting stimulation for language during that period of time, they have an optimal opportunity to develop the language that they need for later outcomes. And as many of you know, who know little kids, language predicts everything. Language predicts behavior problems, whether you have them or not. Language predicts reading. Language predicts whether you're going to be able to manage yourself and regulate yourself in school. So it's a very important developmental milestone. And if you look at these data, it suggests that we want to make sure children are getting this kind of language stimulation at this time. But importantly, from a prevention standpoint, it further suggests that we should be doing a lot of work around prevention in these early years. And I often like to point people to that purple part of the graph, which is about higher cognitive functioning. You'll see that the peak is really much later, about a year old, but look how long it takes us to get those kind of higher complex skills. Not until adolescence, which explains why adolescents seem so crazy to parents like me who are raising them. So, all right, but this is another study that I'd like to talk about, and this one is about the Romanian orphanages. I think many of you probably have heard about what happened in Romania under the dictatorship of Ceausescu, and what has happened in many other countries was this real emergence of the orphanage as a way to take care of poor children. Now, of course, in this country, we don't do things like that. So, but many of American scientists and Canadian scientists and scientists from Great Britain have gone over to look at these children. And this particular study was by Michael Rutter, who's a psychiatrist out of the UK, and he was comparing children from the Romanian orphanages to children in Great Britain who were adopted. So he was comparing them to a reasonable sample. So if you look at the kids who came out of the orphanages prior to 6 months of age, they looked about the same as kids who are adopted in Great Britain, okay? And this is looking at their level of cognitive impairment. Now, Look at the kids who exited the institutions when they were between 6 to 24 months of age. You see an exponential increase of the children who have cognitive impairment, up to about 12, 13%. But now look at the kids who didn't come out until after 2 years of age, right? You see about a third of those children are going to go on to have cognitive impairments. Now, what does this suggest to us? Think about this from a brain development standpoint. It suggests that children who are experiencing chronic neglect, right, which is what you can sort of think about in terms of institutions, children who are experiencing chronic neglect, who don't get out of those situations early on, hopefully prior to 2 years of age, even better, prior to 6 months of age, are much more likely to have these impairments. And what the scientists who followed these children, now some of them are following these kids and they're 20 years old, they've suggested that the mental health impairments are even harder to overcome. So what does this suggest to us? I am not at all saying that we need to place all these kids who are experiencing chronic neglect into, better foster homes or put them into adoption. What I'm arguing is we have an opportunity to address the needs of these children by intervening into their families early on in the developmental trajectory. And that's been what I've been spending the last decade or so trying to do. Okay, now this, you all I know have heard of ACEs. Everybody in this audience, I'm sure, have heard of ACEs, adverse childhood experiences. And I like to say, social workers have been studying and working on adverse childhood experiences for 100 years. But now, because physicians have figured out that it's related to later health problems, now all of a sudden it becomes au courant. But certainly it's something that we've always worried about and known about. Children experiencing things like substance abuse and depression and racism and homelessness and poverty, all those kinds of things really have impacts on children's outcomes. But what I like about this particular diagram is that they talk about the pair of ACEs. So they're not just talking about the adverse childhood experiences that come from experiencing a certain kind of family. They talk about these root factors that lead to these family conditions, including chronic poverty, discrimination, structural racism, poor housing, and violence. So what I really like about this particular diagram is that it tells us that not only do we have to do our regular work with families at the family level, but as social workers, we have an ethical responsibility to always be advocating that our clients don't have to experience these kind of root causes that lead to these problems, but also we have to incorporate those in our assessments of families, thinking about what we can do to try and help them have better outcomes. Now, I want to talk to you about this idea of toxic stress. And any of you who have heard Jack Shonkoff talk has heard this issue. And I really like to use this conceptualization because what he argues, and he's done a lot of work around young children exposed to early adversity, is that these kinds of experiences get under the skin. And it's because they get under the skin that we get these kind of poor outcomes that we see in children experiencing chronic poverty, but also children in the child welfare system. But what he also says is that we all experience stress at some point. Sometimes it's short-term and low impact. Sometimes it's a big hit. Like, if you lose your parent or as a young child, or if you're exposed to chronic violence. The issue that he raises, however, is that the stress does not become toxic until you are in a situation where you don't have protective relationships. And that's that fuchsia that you see, right? That's that toxic stress. It is the chronic activation of the body stress response system, because what they argue is that, right, stress gets under the skin when it's chronic and high impact. But if you have protective relationships to help you through the big life hits that many of us get, that you don't have the same outcomes. And why is that so important? It's because it means we can do something about it, right? We can create a set of protective relationships, even with children's birth families, that allows them to have a different set of experiences and hopefully better outcomes. So here's Jack's biodevelopmental framework, right? And so he argues, like many of us do, that the toxic stress comes from chronic poverty and racism and trauma. And the worst kind of trauma, of course, is maltreatment, because it's direct victimization of trauma. And as I mentioned, they talk about it getting under the skin. So what many people have done, and we've even started to do in some of our own work, is look at cortisol production, right? Which is, you can look at in a very non-invasive way. Never thought as a social worker that I'd be doing this, but nowadays to get a brand in toxic stress, you almost always have to have some kind of physiologic measure. So we were collecting saliva from mothers and babies, and what you can do with saliva, very non-invasive. The parents say it's yucky, but they don't mind giving it to you. And babies, it's really easy. You just put a swab in their mouth and you take saliva from them. But you can look at telomere length, that little cap on the edge of, on the top of a neuron that's related to cellular aging. And they can look at how in certain poor moms, for example, you see shorter telomere length, which suggests that their cells are aging faster than women who are not experiencing the kind of stress they are. You can look at immune system functioning, all those kinds of things. But the point to make here is that it's not just the behavioral manifestations of this stress, it's what the stress does to your inner workings. And that overabundance, for example, of cortisol, you can imagine your body just having this stress hormone going through your body, that is going to lead to bad outcomes. So think about a little Head Start child, a 4-year-old child in Head Start who's anxious. He just lost his father due to violence. His mother is depressed because of it and she can't get out of bed. He's had to pass by violence on his way to the Head Start Center. His little body's going to be producing cortisol at levels that might be really high, or alternative, may have just shut it off because the world is too hard. Why do we wonder why that child is presenting with behavior problems in the classroom? Why do we wonder why that child can't learn his ABCs and 1, 2, 3s and all the things that they're trying to teach children in early care and education? Part of it is because that child is experiencing such high levels of stress. Okay, so I want to talk to you now about a study that I've been working on. As I mentioned, I got very, very interested in this public health issue about poor birth outcomes among African American women. And most of my work is community-based, kind of on the ground studies, where I'm trying to learn from families in the communities in which I work. So this was a convenient sample of African American moms that we looked at. We had about 125 moms in this sample. And what we were interested in is whether we could predict adverse birth outcomes through a variety of things that we asked mothers about during pregnancy, right? We were also interested in looking at things like mother's material hardship, her psychological distress, her racial discrimination, and whether those things also related to birth outcomes. So we actually did 3 time points of data collection. We followed these moms from the second trimester of pregnancy through the first 6 months post-birth. And so we asked moms a ton of questions during pregnancy about depression and all that kind of stuff. We did a developmental assessment of their babies when they were 4 to 6 months of age. We did a parenting observation at that time. We collected saliva, which I'm not going to talk to you about because actually we're still having it assayed. And we talked to moms post-delivery about birth outcomes. So let me tell you one of the things that we discovered. So one of the things that was most surprising to us, because we certainly expected prenatal depressive symptoms to predict birth outcomes, we certainly expected prenatal health practices to predict birth outcomes. But when we looked at all those things together, the thing that was most significantly had the highest effect size was prenatal trauma history, whether these women had experienced abuse. And that predicted their birth outcomes, which is consistent with what some researchers are saying about the high allostatic load that African American women are carrying. That if you've experienced the trauma that comes from racism, but also in this case, the trauma that comes from direct victimization, you're much more likely to have adverse birth outcomes. So that's one thing I wanted to share with you. The other thing I wanted to share with you about this study, and we're still doing lots of analyses, we're now coding the data on the parenting, but we also found that this SES risk variable that we were looking at, which really was income and education and employment all together, prenatal health practices and prenatal discrimination predicted postnatal depressive symptomatology. So we know that postnatal depression is a big issue for moms. It causes a lot of abuse. You all might know about the crying that occurs, the purple crying that occurs in the first 6 months of life. And what mothers report is that when they shake their babies, it's because their babies are crying all over the place. So we were obviously very interested in thinking about what predicted postnatal depression. And we certainly discovered here that prenatal discrimination, mothers' perceptions of discrimination, was a significant predictor of postnatal symptomatology. And this was particularly important for mothers who had greater SES risk, which always, is important for me. I always want to think about what moderate these kinds of outcomes, what kinds of factors moderate these outcomes. And we certainly saw that mothers who reported higher SES risk were much more likely to be affected by experiences of prenatal discrimination. We also found that prenatal discrimination predicted adverse outcomes. And now we're starting to look at the baby scores on the Bailey, which is the major assessment tool. If anybody's knows about assessing babies, the Bailey, that we're seeing that prenatal mothers' perceptions of discrimination prenatally also predicted her child's development. So this is important for us because we want to think about, again, promoting kids' outcomes. So I talked about that study, but now I want to shift to what we can do about it, okay? So clearly, I hope I've made the point that not only is infancy a time of vulnerability in terms of what kids experience, in terms of inequities and disparities and service trajectories and all that, it's also a time of opportunity. So when you look at this particular graph, what it argues is that if you give early experiences that are positive, right, the brain is much more likely to change and adapt to those kinds of positive experiences. So you can look at it negatively and say kids get lots of terrible hits when they're young and it doesn't help them to have good outcomes. But you can also look at it positively and say, in terms of return on investment, if you give them as much support and as much intervention early in their lives, you're much more likely to have positive outcomes. And again, from my vantage point, what this argues is this is when we need to be doing as much as we can to prevent these kind of adverse outcomes for these children. Now, at the same time, as I said, advocating for these kind of structural changes, right? Because that has to be part of what you think about, that will help children not have to experience chronic poverty and not have to experience structural racism. And that's part of our code of ethics as social workers, but also for the clinicians and the service providers on this in this audience, there is something we can do. And it goes back to that Jack Shonkoff statement about the protective relationships. While we're advocating for children not to experience chronic poverty, and maybe, as Jane has said, now we have a child allowance, first time ever in this country probably, right? That maybe we won't see as much child poverty, but while we're working on that, there are things we can be doing to help these children's outcomes as well. So I like to think about this from a public health standpoint, right? That there are three pathways that we can address this kind of early adversity. We can think about it from a primary prevention standpoint, where we're addressing all these kind of structural disparities as we talked about, but also there are many community-based public health approaches that are now available, like Family Connects, where you go to the hospital and every baby, every mother at delivery is offered 1 to 3 home visits. It's all voluntary, so the stigma is taken away from it. And they have found with programs like Family Connects that it reduces ER visits, which is one of the things that we often look for abuse for children, and for little kids, even neglect because of those near misses. So these kind of community-based, population-based public health approaches seem to have an impact on the numbers of children who end up in the child welfare system with maltreatment, referrals, etc. On the secondary prevention side, these are for children who present with very, very high risks, like children who are growing up in families where there's substance abuse, or children growing up in families where there are mental health problems. So you know that these risks are there, and there are programs that are designed to address the needs of these particular families. And I'm going to tell you about one that we've used in just a second. And then on the tertiary side, which I don't do as much on, when I was a young social worker, that was all I did, tertiary prevention, where you're looking at kids who have already been designated as maltreated, and you're trying to avert foster care placement, or you're trying to get these kids reunified, etc. And I would argue that we have done a really, really poor job of providing the kind of preventive services that allow these children to be able to stay in their families. So that's another thing that we have to work on, but most of my work has been square in the middle in the secondary prevention side. So the other thing I want to argue, in addition to this idea of thinking about it on these three levels, right, and really thinking about it from a triage perspective, that, you start with the population, and then you figure out who needs a little more, and those families get a little more, and then you figure out who's really, really at high risk, and you give them the most intensive intervention that you can get. So that's that kind of public health three-level model. But I'm also arguing that we really need to have an integrated system of care. There is no way that children in the child welfare system, or children who are at high risk for child welfare involvement, can just be supported by child welfare by itself. We have to have an integrated system that pulls in all these different players who are providing services. And what you see when you get all the service providers in the room, they're serving all the same families, but it's done in silos. So what we're arguing for is this integrated system, and certainly these programs like Family Connects is trying to do that. But the other important thing about it is that should be developmentally centered, right? That one size cannot fit all. What we do for adolescents is different than what we're going to do for children who are in middle childhood, and it's certainly different from what we want to do for children in early childhood. And I would argue that there are many systems in the early childhood space, which is the space that I work in, that should be prioritizing these children and should be working together. And I'm just giving you some examples of programs that are trying to do this. So on the pediatric side, I'm on the board of 0 to 3, and we're doing this big systems level intervention called Healthy Steps. That is providing a developmentally oriented set of supportive services in the pediatrician's office, right? Not the child welfare office, because child welfare has stigma, etc., but in the pediatric office. And most parents are going to take their children to the pediatrician. They may not do everything else, but they're going to take their children to the pediatrician. So this idea is to have a developmentalist in the pediatric office who can make sure to do that kind of triaging that we're talking about, and making sure that families who are really high risk get those kind of tertiary level services. Early Head Start is another example, right? Primary prevention, if you sort of think about low-income children as a population. Secondary intervention, if you sort of think about low-income children as being at high risk for poor outcomes. Either way, there is an early care and education system that's at the national level and at the state level and at the local level that we can be using to have these children prioritized. And I've said this so many times, I could say it in my sleep. Every child in child welfare should get a priority slot in early Head Start. And Head Start is something I've been screaming about for 10 years. And certainly there is more of a progress in that area, but certainly what these kids get is comprehensive assessment. And again, these kind of triage services, but also they get an opportunity to get the stimulation they need while we are working on getting their parents to the point that they can give that kind of supportive, responsive care that we know is so important to combat against toxic stress. So I'm going to tell you about another study that we have just sent out for publication. And honestly, I typically do community-based work, 100, 200 kids in a sample. This is the biggest study that my lab has ever done. We collected data on 1,000 kids in Baltimore City, 500 in the first year and 500 about in the second year. And we were looking at the evaluation of pre-K. And what we were interested in, and you all probably know a little bit about Baltimore City, is where the Freddie Gray riots were, lots of poverty, primarily African-American urban area, lots of housing problems and violence and all those kinds of things. And of course, what I wanted to know is, can we help these little kids who are experiencing all this get better? So we used a regression discontinuity design, again, which is not something you hear much about in social work research, but in early childhood, it is a design that's often used, borrowed from our smart economists for the most part. And what you do is you recruit a sample of children who are experiencing a treatment, right, in 1 year, and then you compare them to a group of kids who are experiencing a treatment, in this case, pre-K, in the second year. You typically are looking at what they call an exogenous cutoff, right? So it can't be anything related to how you are collecting the data or anything like that. Somebody has to decide this cutoff arbitrarily. And in many states, there is an age cutoff for getting into pre-K. In Maryland, it's age 5 by September 1st. So for the most part, if you get pre-K, you have to be 5 by September 1st. If you turn 5 on September 2nd, you don't get to go to pre-K until the next year. So this is viewed as a very rigorous way, almost as rigorous as a randomized controlled trial, but much more ethical, because you're not really saying that a group of kids who need this don't get to get it. You're looking at this exogenous variable as a way to decide which kids go in the treatment and which kids go in the control group. So you look at these kids in the treatment group at pre-test and post-test, and then you compare the kids at post-test to the kids who are entering pre-K the next year, with the idea being that these kids are very similar, even in terms of age. So you look, the way the RDD experts had us do it, we had to look at kids who were 90 days out of that cutoff. We had to look at kids who are 180 days outside of that cutoff. And then we had to look at kids who are 360 days outside of the cutoff. And what you want to see is a difference between these two groups of children at each of those cutoffs, at each of those age spans, to be able to say that pre-K worked, okay? So let me tell you what we found. And this is low-income Baltimore violence ridden. that when we looked at our assessments, and these were sort of traditional early care and education assessments in the field, we looked at Woodcock-Johnson language and literacy, numeracy and math subtest. We looked at the Peabody Picture Vocabulary Test, which is a test of receptive vocabulary. And let me just say a word about receptive vocabulary. That is understanding language, which is really, really important, because a lot of times you see you can't get expressive language out of kids. So this is really an important kind of variable to look at. And then we looked also at executive functioning. And actually it was the teachers, because one of the things that we always do is go out and we talk to the community and we try to get them to help us think about how we should be doing these studies. It's part of community-based research, but they always help us figure out a lot of things that we haven't. And we were just planning to use the Woodcock-Johnson and the PPVT. And the teacher said, oh my God, you need to look at something that helps you to look at these kids' regulatory capacities, how they're working, how they're problem solving. And executive functioning is a big, important thing in the developmental field now. Jack Shonkoff calls it kids' air traffic control system, where they're able to, focus and problem solve and use their memory to help them solve problems. So it's really, really important for young children. So let me tell you what we found, that the kids who got pre-K did better on 2 of the pre-literacy language subtests, not on passage comprehension. And passage comprehension, for those of you who can't remember these kinds of tests, is really understanding text. So for a little kid, I will tell you, our kids just bombed out. There was just hardly no variability, whether we looked at the kids prior to pre-K or whether we looked at the second group, it just was hardly any variability. So we sort of see this as a later outcome for children, even though certainly middle-class children are doing fine on this test, but we know that children from low-income backgrounds are not performing the same. Similarly, on the numeracy and math subtest, we saw that the pre-K children did better. We saw that they did better on that measure of receptive vocabulary. However, when we looked at executive functioning, the effect was not robust. In other words, we saw it at that 90-day cutoff. But again, what the experts in RDD tell you, that you need to make sure that you got that finding at 180 days as well as 360 days, and we did not get it at all those kind of outcomes. Again, which suggests to us executive functioning, which is emerging during the preschool period. When you look at middle-class children, they are doing all of this. But for our children, they really bottomed out. So what it suggests is that this pre-K experience is helping with these kind of literacy skills and language skills that are critical for later functioning, numeracy skills that are critical for later functioning, but there's a lot more direct, explicit, intensive intervention that needs to be done on this executive functioning side to get the children where they need to get. Okay, I'm going to tell you about another study, very different study that we've done on ABC, attachment and biobehavioral catch-up. And this, very different from this kind of what I consider a primary prevention like pre-K. This is really more a secondary preventive intervention, where we were trying to address parenting. And what we did was add ABC as a supplement to Early Head Start. I don't know if you all know about Early Head Start, but it is the younger cousin, if you will, of Head Start, whereas Head Start serves primarily children 3 to 5. Early Head Start serves children 0 to 3. It is a much newer program, but it is our largest program for low-income infants and toddlers in this country. Now, there was a big research and evaluation project done on Early Head Start, and interestingly, what they discovered was that Early Head Start really did not benefit the higher risk families, that it was great for your sort of what I call the poverty families, but the poverty plus families who had other kinds of risk factors, it just looked like there was no benefit. And by the way, that's really buried down in the report. It's not something that people talk about very much. But what the Early Head Start folks decided to do was to have this new grant that helped to look at how we could buffer toxic stress in early Head Start families with the idea that maybe we could get at some of these higher risk families that early Head Start generically was not able to address. So we did a study of ABC with primarily Latin American families. We had 208 families randomly assigned to receive ABC or not. Now, mind you, what that means is that our control group was getting early Head Start. They were getting early Head Start home-based services. One of the first things that we discovered, and the Head Start office was very clear, we could not stop them from getting their Head Start services. So imagine us thinking, oh my God, we're not going to get effects because they're already getting something and we're just adding this very brief intervention. ABC, for those of you who don't know it, is a 10-session intervention. It's very intensive where you're focusing only on 3 target behaviors. So you're only focusing on nurturing, trying to get the family to be more responsive to the child's cues, etc., following the child's lead, and reducing frightening behaviors. That's all you can work on. You can't work on safety like we would in another child welfare intervention. You can't work on case management. You can't do anything. You focus on these 3 things. And Mary Dozier, who's the person who developed this intervention, argues, and there are many people in the parenting sphere who make this same argument, that the reason parent education does not get you change in parent behaviors, it gets you changes in parents' knowledge about what's appropriate, but you don't see behavior change, is because we're going all over the place. And it's very didactic. And we're talking about alternative modes of discipline. And we're talking about child developmental milestones and all that stuff all over the place. So the content is not explicit. But the other thing that they argue is that this didactic approach where you're sitting on the couch talking to parents does not work, that what you need is a more experiential coaching. And what Mary Dozier calls it in ABC is in the moment commenting. So what you see is a parent coach constantly observing parenting behavior, connecting that parenting behavior to these targets that Mary Dozier says you're supposed to work on, and then helping parents to see how changing their behavior, and you don't work, you give a lot of positive feedback. That's the other kind of thing. It's not really negative, but how that kind of in the moment commenting leads to changes in their behaviors, which leads to better kid outcomes. So we did this randomized controlled trial, and I'm just going to tell you what we found, that indeed, even though we were really worried because, again, our control group was still getting home-based services, but just it was early Head Start as usual, that we did see improved sensitivity and reduced intrusiveness in these families. So even though they were getting early Head Start, this addition of a brief parenting intervention, and I will tell you all, we used ABC, but there are many others around. There's FINE coming out of University of Oregon. There's Promoting First Relationships that's coming out of University of Washington. These very intensive short-term programs that can be made as part of a family visitation plan for reunification, as far as I'm concerned. And actually, there's a group trying to do ABC as part of a family visitation plan. You can get these kind of outcomes, which we were able to get. So that's one thing. But then we wanted to ask this other question that's a big question in the prevention literature about what works for whom, right? We wanted to move beyond the main effects model. And that's what a lot of prevention researchers are talking about. And let's think about who is getting the most out of these interventions. So we decided to look at parents who were at high psychological risk, and we looked at things like maternal depression, maternal anxiety, but also remember, this issue about maternal trauma. We got to add that because we were even seeing maternal trauma experiences predicting birth outcomes, right? So we looked at mother's history of child maltreatment, but also her history of intimate partner conflict. And what we found was that there was a moderated effect. So when we looked at dyadic mutuality, which is this responsiveness that ABC is supposed to improve, right? How parents, and unfortunately, I apologize, these are just mothers. I'm not at the point where we're doing this with fathers, and neither has Mary Dozier with ABC, but this is just mothers, that this mutual back and forth, Jack Shonkoff calls it serve and return, is what he calls it, even though I don't particularly care for the tennis metaphor, but I do like the idea of contingency and things like that, that you see that particularly improved in the group of moms who were at high psychological risk. And when you look at reduction of behavior problems, you see that in the moms who are at high psychological risk, but no movement in terms of behavior problems for the moms who are at low psychological risk. So what does this suggest? Again, thinking about this from a secondary preventive standpoint, that using these intensive interventions that are explicitly designed to change parenting behavior can help improve parenting behavior, but also can help improve child behavior, particularly for parents who are at high risk. Okay, so I'm going to stop so I can open it up for questions. And what I just want to conclude by saying is that I hope I've convinced you of the import of intervening in the early years, right? We know from all kinds of research nowadays that wasn't there when I first started my work as a clinician and a preventive person in Brownsville, Brooklyn, and New York, right? That there is this plasticity that occurs during the young years that makes children more vulnerable to adversity. So that's why we see greater and longer impacts of poverty and other kinds of things on when young children experience these things early on. But on the other hand, we also see much more responsivity to change. So if children experience that protective relationship, the positive, stimulating, responsive caregiving that Jack says can combat against toxic stress, buffer children against toxic stress. And again, make sure you hear me. I'm not talking about placing them for adoption or placing them in foster care. I'm talking about doing the kind of parenting interventions that will help them. I'm talking about putting them in an early care and education setting that will provide this kind of thing, that these children can have better outcomes. And certainly we see it in the data that we have in my own research team, but there are many other people who are looking at this. I want to emphasize the importance of looking at evidence-based strategies. Again, when I started as a social worker, we were not thinking about evidence-based practices. We were just going with what we knew, right? And I was trained as a psychodynamically oriented clinician. I was doing a lot of play therapy with 2-year-olds, which I'd never do again. I'd be doing some kind of parent-child interaction kind of approach where parents are doing the work and I'm trying to work through the parent. That's my mechanism to get at child outcomes. And then the importance of really trying to think developmentally. So not having this one size fits all idea, but thinking about what we know about children's development, what they need, what we need from parents and caregivers to respond to children, to get their outcomes moving in the right direction. And then this idea of an integrated service system, because certainly in child welfare, we cannot be held responsible for child well-being all by ourselves. So with that, I'll thank you for listening and I will open it up to questions. I'll stop sharing my screen now.
Brenda, that was phenomenal. What a tour de force. It feels like it was an entire course on child welfare and early childhood development in the course of less than an hour. So that was just amazing. I mean, I loved the whole talk. I especially loved the pair of ACEs. Like you, I've always been very skeptical about suddenly the medical community's discovered adverse childhood experiences. Like, give me a break.
Right. We've been doing
but
this
marrying that with the root causes, with poverty and structural racism, I think really amplifies that. And the illustration from your study was really sobering. Your perinatal study. So that just was so powerful. So there are a lot of questions from people in the audience about what can we do in the child welfare system, or what can we do in the homeless shelter system? We have in front of us such immediate needs, safety needs, housing needs. what can we do to address these really severe developmental needs that you've identified? And it sounds like, your your approach of integrating with other services sounds like it's really really helpful there.
Yeah, well, that's the first thing I would say, that, right? We know that these kind of big hits for families, like being homeless, we can't solve on our own. And I remember being a social worker in Brownsville, Brooklyn. Every one of my families had housing problems,
Yeah,
and I
yeah.
often felt like there was nothing I could do. Um, Certainly, I think advocating and advocating and advocating makes sense, not just on an individual level for our families, but part of our social work ethics about trying to address this issue writ large. But I will tell you, one of the things that I have learned is that there is still something you can do in the face of all those problems. And that's the message that I want to give to the clinicians in this room. And I still supervise some folks in some of the interventions we're delivering. And I always do this little box like this. And I say, you know, don't let yourself get overwhelmed by the enormity of the problem. Think about what your contribution can be. And what Jack Shonkoff argues, and we've got data to support this now, right? In ABC, for example, but not just ABC, that if you can focus on the parent-child relationship, the kids can still get better outcomes. And here's the other thing that we found. We did a qualitative study to just ask moms about what they thought about ABC. And these were moms, these were primarily Latinas, right? Who had experienced immigration trauma, IPV. I mean, just the trauma, you can just go down the whole list. And what they said to us was, we taught them how to have fun with their babies.
Yeah.
Now, you know, okay, so they're not saying you help me be a better mom. They're not saying you help me to deal with my immigration trauma. They're saying you help me to have fun with our babies. And what we saw those moms doing was doing better parenting.
Yeah.
So it didn't fix the trauma. It didn't, fix all the worries, the financial worries they had. But there's a saying we have in 0 to 3 about babies can't wait.
Yeah.
Babies can't wait for us to fix all the problems. All babies care about is somebody feeding me? Is somebody changing my diaper? Is somebody picking me up when I cry? And so I just want to say to the clinicians that there is something you can do. And certainly getting kids in the early care and education system, to me, should be the first thing on everybody's list.
Yeah.
The first thing.
Yeah.
And 'cause, mind you, what happens in early care and education? They get food, they get a space where they can experience light and play. And again, we still have to do all this other stuff, but we're giving babies an opportunity to have those experiences early on.
And the mom gets a break, so the mom
Yeah.
gets a break, and as you've been, emphasizing, it's not either or. It's, sure, advocate for housing, advocate for all the structural issues, and provide an evidence-based parenting program, and provide early Head Start or early childhood care education. Yeah, it's and not, yeah.
Yeah.
So there's a similar set of questions about, I guess it's what you in your framework would be tertiary prevention. What about the kids? They're already school age, so they've passed through early childhood and they're showing up in school with really significant trauma. School age kids or adolescents. A lot of the practitioners, who are watching this talk are working with older kids and are wondering, what can I do when I have kids who have experienced the kind of things that you've been talking about?
Yeah, so we have been working with some school mental health people around these issues in Baltimore because, as you know, as I mentioned, Baltimore is one of these places, I wish it weren't true, but man, oh man, the trauma that these kids experience, the violence that they see, people getting murdered in the streets all the time. And so what the school mental health people have been doing are a couple things. One, going in and helping the teachers, because one of the things that we've discovered, of course, when you talk to teachers in these situations, they are so overwhelmed with these children's behavioral problems. So one of the big things is to provide mental health consultation to teachers. And that has a couple of different steps to it. One, helping them to not see children as a behavior problem, but to take a moment and ask why. And what they say to teachers, and again, I do it, my work is with teachers in early care and education settings, but my colleagues in school-based mental health do the same thing. They ask the teachers to try and find out the why. Why are children acting the way they are? And what they find is that 90% of them have been traumatized, which is why, you know, they're acting that way. So, and I'll give you one example from my own research with school-age children. We were doing a study where we were looking at kids' violence exposure, school-age children violence exposure. And of course, it was off the roof. And we were doing this debrief with the teacher in the classroom. And this teacher I was in the classroom with was in tears because she had no idea that these children had experienced this kind of thing. So that's one thing, helping the teacher to understand the trauma behind the problem. But the other thing is to give something to those teachers, to fill them up, if you will. The same way we think about parents, you fill them up so that they can take care of their children. You're filling up these teachers so that they can be less reactive to kids' problems. So doing things like mindfulness with teachers and things like that. So that's one thing. But then also trying to help the parents with the same thing. So now, of course, we're all in a telehealth mode. What we're finding is you can get to parents more with telehealth, right? Than when you ask them to come to the school and talk to you. So getting to parents through telehealth to help them understand the same kinds of things and to do mindfulness and things like that with them. Now, in terms of the kid, and then I'll move on, but this is a big complicated issue. Whereas for younger children, I would never do individual therapy. I just think it's a waste of time to do individual therapy with younger children. But for older children, you can. And one of the things that my colleagues who work with school-age children talk about is having them come up with a narrative around the trauma so that you really help them to talk about it in a way that is almost cognitive, right? And creating stories around it and books around it where they talk about it. But as part of creating that narrative around the trauma, to think about where their safe places are. So who can they go to in their families? Who can they go to in the schools? That kind of thing. But also coming up with the safe places in themselves. So that's that kind of tertiary thing. And I think there's some beautiful models, certainly in the early childhood community, like child parent psychotherapy, beautiful models that address those kind of tertiary things that kids who've experienced this kind of trauma have to contend with, that have nice outcomes, by the way, in terms of improving children's mental health.
Yeah, and this is just such a growing area of interest among researchers and practitioners both, this notion of trauma-informed care and practice. So yeah, so there were also questions about the moms. I think several people in the audience were really struck by the kind of trauma that you were describing, especially in that perinatal study, that the moms had experienced, both, you know, sort of personal trauma in terms of abuse, but also experiences of discrimination, experiences of racism. So what can we do for the moms?
Yeah. And, you know, we have started adding, I'll be honest, the everyday discrimination scale to every study we do now. We've done it. Yep. We've just started this is the 4th study that we've added it to. And in every one, this self-report perception of discrimination measure, right? That's all it is.
Yeah.
Predicts maternal functioning in every last one of our studies. So I am kicking myself that I was so ignorant and didn't include it before. But again, I think you have to think about it as trauma, right? It is trauma when you feel like the world treats you less than who you are.
Yeah.
Now we're looking at it with African American families, but there are colleagues of mine who are looking at this same issue with Native American families as well. And one of the things that's part of not the parenting interventions, but the interventions around race is sort of helping to validate who these parents are, but also to help them face squarely the experiences of discrimination that they've had. So, you know, a lot of people don't like this term of microaggressions, but giving them a space to talk about the microaggressions they feel. But for us, helping them to make that connection to what it means for how they take care of their children. Like, are you letting your stress when somebody calls you a name or you know, runs across to the other side of the street, are you letting that affect how you take care of your child? And what does that mean for how you want to socialize your child in terms of race? And what does that mean for how you advocate for your child in spaces where you think they might experience those? And so what happens in these kind of interventions is, one, mothers get to put it out there where, you know, they don't get to talk about it much, but also they get validation that what they've experienced is real. And a lot of times these are done in group formats. Their experiences is real and are validated, and they can do something about it. So it's a very empowering kind of thing, where you can help them name the microaggressions, but also give them the terms that people are using, like implicit bias and things like that. So it's a very kind of cognitive approach, but it's done in this way of providing a validation and support, which is what we do in these kind of parenting interventions anyway. And we always are trying to help moms make the connection between what it means for how they parent their children and what it means for their own mental health.
Yeah. No, that's fabulous. I mean, I was going to ask in your in the study where you were looking at discrimination, it sounds like now you're doing it in all your studies. Just for the people in the audience, can you say how common this is, this experiences of discrimination? Because I think people may not be aware of how prevalent this is.
Right. So it has varied. I've said we've done it in 4 different studies. So it's varied, but it ranges from like 40 to 60%. So it's pretty high. It's pretty high.
Yeah. That was now,
all of our moms are low-income African-American moms. I've not tried this with Native American or Latina moms at all. So this is just low-income African-American moms.
Yeah. Yeah, we're now asking that question in the study that we do in New York City, the poverty tracker study. And I think it's at least 60% of the African-American sample are reporting experiences of discrimination on the basis of race.
Yeah.
Yeah, it's incredibly widespread. I see there's a lot of questions in the chat, so I might just take a look and see. I want to do justice to the folks in the chat. Well, someone wants to know, do you have enough funding for your excellent research? So isn't that a great question?
Yeah, we never have enough. but
goodness, I don't know if somebody is intending to make an offer or like what.
We never have enough, so I could certainly use additional funding. But I will tell you, I don't get much funding from NIH. I will tell you that much. But I get a lot of funding from Administration for Children and Families. I think they are really interested in these questions, and the foundations are really interested in these questions. And I've gone to like foundations that I wouldn't normally think about. They're not like the big ones. I mean, I've gotten money from Kellogg before, but I've gone to like these family foundations locally, and they're very interested in these issues. So that has helped me all along. But
Yeah.
as Jane knows, we never have enough money. Well, part of my problem is we're trying to also do intervention research, which is
Yeah, that's
a
tough.
lot more
Yeah,
expensive.
that's
Yeah.
tough.
Yeah.
So, you know, we're talking today, it's March 11th. It's 1 year since the World Health Organization declared a pandemic. It's been a rough year. So there are a lot of questions about COVID. What's been the impact on the kind of families that you're talking about? What's been the impact on the communities? How has it affected your work and the studies that you carry out? How are you doing? You know,
Well,
I think people kind of want to, you know, acknowledge the moment, and we're not through it yet. Things are getting better, but hopefully we're turning a corner. But what's the last? What's been the impact of the last year, and also what's going to be the impact coming out of this
right.
for the
So,
kids who were babies and infants and toddlers this last year?
right. So let me answer the methodological question first. We've pivoted to virtual like everybody else
Yeah.
has. So we are getting data from moms over the phone. They all have smartphones. They may not have a computer, but they have smartphones. We even are doing the Bailey screener on Zoom. So we'll see how that works. But we're doing the
Whoa.
Bailey
Okay, we need to
screener
have
on
a follow-up conversation about that, because we've been struggling with how you do mother or child assessments online, and some of our colleagues are starting to do that. So you're doing the Bailey.
We're
Whoa.
doing, you know, let's see how it works, Jade. I mean, we just started this. We have about 40 moms that we have have tried this with. So we'll see how it works. But so you just have to go. That's what you do as a social worker, right? You go with the punches. So we just go with the punches. But
Yeah.
but back to the more important question. There is a group, I'm on Phil Fisher's advisory committee, where he's doing this weekly survey of parents of young children in the midst of COVID.
Oh.
And it's a beautiful project that's funded by foundations.
Yeah.
And I'm happy to share the link. He does these little blogs and things. But the upshot is, and everybody would know this, that the levels of material hardship have just gone through the roof.
Yeah.
So parents, low-income parents in particular, are reporting that they can't pay their utility bills and they can't pay their rent.
Yeah.
But what's important about those material hardship findings, which we could have predicted, is that he finds a relation with maternal functioning when you ask them about depression and anxiety, and a relation between what they say is happening with their kids.
Yeah.
So you see higher rates of mental health problems in the children. If that wasn't enough, when he breaks it out by race, of course, like we know about health disparities when we're thinking about the death rates in COVID and the morbidity rates in COVID, that you're also seeing African American and Latin American families reporting higher rates of material hardship and more anxiety and more, depression for moms and obviously for the young children. The other thing that's interesting is that they're not able to use childcare in the way that middle class moms are.
Yeah.
And they're the ones, I would say, who need it more, because unlike me, who can sit at a computer, these are parents who are essential workers. So they have to show up and clean up buildings, and they have to go to the Amazon packing plants and the meat packing plants. So, and obviously that means that they're more susceptible to getting sick, but it also means they need childcare, and they're just not able to access childcare in the way that their middle class counterparts are. Although, as you know, Head Start and early Head Start many of those places have stayed open, but because of state requirements, they can only have certain numbers of
Yeah.
children, and parents
Yeah.
are afraid. But the bottom line is they're really suffering. And we actually are also, the 43 parents that I mentioned to you, we're sort of looking at not parents who have gotten sick from COVID, but what the COVID experience is like for them. And they're, they're reporting, and ours are, families that we're interviewing over the phone or over Zoom. They're reporting the same things that Phil's families are reporting in this weekly survey.
Yeah.
So lots of material hardship.
Yeah.
One interesting finding that I still can't figure out is they're relying on their kids. When you ask them, because I wanted Phil and those to look at what are the protective things, what are, some things. And so they ask questions like, who are your supports? And they're reporting that their kids are their supports, which made me very anxious, actually.
Yeah.
So,
well, my colleague Jean Brooks Gunn talks about, there's that theory about tend and befriend, and when you're very stressed, this theory, when your parents are very stressed, they draw their children closer to them. So it could be that that's what's going on. But I mean, the other worry is this is a whole cohort of children who haven't gone for checkups, they haven't gone to childcare, they haven't gone to school, for good reason, for public health reasons, they haven't been visible. So this is a whole cohort of children who haven't been reported to CPS.
Right.
So we really don't know what's
going on in those homes at all. We don't. And you're
know.
right. The child care providers and the pediatricians are our sources of support, are our sources of reports for young kids, and the rates are going down. I mean, I do know that a lot of Head Start programs, because they can't bring the kids in, and the federal government, to its credit, kept paying these teachers. They are doing things like drop-offs for foods and things that'll bring family stress levels down, drop-offs of material for kids. One program we work with in my area was having weekly park play visits where the moms sit down and while the teachers let the kids run around. So I think in terms of concrete resources, at least from the perspective of Head Start, those are there. But they're certainly not learning anything on Zoom.
No, but that's a great story. I wasn't aware that Head Start and early Head Start had stayed open and were playing that kind of role. And that's a story we should get out there, because they're crucial supports. And the fact that they found a way to stay open, even if it was for part-time and part day, that's really to their credit. So we have someone else in the Q&A. Honestly, I've never seen this before. Someone else wants to know how they can contribute to your research. And so
I will give you my email address. I always am searching for money. This is Jane, right? Isn't this our life? We're always writing the next grant.
I mean, this was a really inspiring talk, don't get me wrong, but this is amazing that people want to, no, it's not. It's great that people want to contribute and help out. So yeah, where can they reach you? They can find you at
bjharden@umd.edu. That's the easiest email to remember. The other one is longer. My social work email is really long. So bjharden@umd.edu. And I will take any little bit, big bit, anything. So thank you so much.
It's fabulous. I'm supposed to wrap up around now. So are there any last remarks you'd like to make? Anything we didn't touch on that?
I just want to put a plug in for really thinking about the littlest of the children. I think what happens to a lot of us is that the children in school, they cause behavior problems. And so they're sent to special ed, and we see them on the street. And so we think they need mentoring or something needs to be done, I really want to put a plug in for thinking about young children and the beautiful opportunity we have to alter their outcomes, not just in the immediate, but in the long term. And, you know, the economists are now doing these return on investment papers. Heckman won a Nobel Prize for heaven's sakes, on how important intervening in the early years is in terms of adult outcomes. And Jane, you've written about this yourself. So I just want to put a plug in for that and encourage people, if they're interested in the young child issue, to go on 0 to 3's website. I'm vice president of the board, so I'm shamelessly advertising them. But on their website, they've just got tons of resources and materials that help us understand this issue of development in the early years, but also what kind of interventions you know, really work for these little kids. So beautiful policy reports as well that you can find.
No, absolutely. I mean, you've made such a compelling case for the harm that could be done, the opportunity to really change trajectories and change lives, and the fact that there really are evidence-based interventions out there that can be applied, you know, even for kids who are in the child welfare system, or to prevent kids from going into the child welfare system. So, and that it's, you know, parenting interventions, and it's early childhood care and education interventions. So, boy, what a fabulous talk. Thank you so much, Brenda, for making time to do this for us in the midst of really such a rough year. We've all learned so much.
Well, thank you. Thank you for the invitation. And it's always good. This is my passion. So I love talking about little kids and getting them on the right track. So thanks for the invitation, and thanks for everybody's attention as well.
Yeah. We'll hand it back to Dean Begg, and I think she'll close us out.
Thank you. What an incredibly compelling presentation. I totally agree, Jane, and several of us, including me, were noting, we think Mary Funnyé Goldson would be incredibly proud and delighted right now with the work that you're doing and moving this forward. So, so thank you. And I also love the fact that your work is hopeful, right? You're not just presenting an analysis of predictors and outcomes, you're actually painting a picture of actionable steps that we can take to make those outcomes better. And I think that's really essential. So thanks, Jane, for moderating, and thank you, Dr. Jones Harden, for sharing your wonderful work with us. You've given a lot to us to think about and to act on going forward. So thank you, and best wishes to everybody who's joined us for this session today.
Thanks, everybody. Bye-bye.
Thank you.
Bye-bye.